What are the different types of wound dressings? You got a wound, what are you going to use? Are you going to use gauze? How about a collagen scaffold? How about a silver impregnated dressing? How about a hydrogel? How about an alginate? What are you going to use? This is what we're going to talk about today at Citizen Surgeon. Let's go. Welcome back to Citizen Surgeon. My name is Dr. Eric Pearson. I'm a pediatric surgeon, and I'm here to scale surgical education, get you comfortable on the wards, in the ICU, in the operating room, and of course, to crush your exams. I am your guide on this educational journey, and today we're going to continue this wound education series by talking about dressings. There are so many different types of wound dressings available that it will make your head spin. If you have a superficial wound, what do you use? If you have a deep cavity, what do you use? If you have a wound with a little bit of exudate, what do you use versus a high exudate sacral decubitus ulcer? There are a lot of options. We're going to make it simple today. Let's go over really quick what we've done so far. So our wound series has talked about 5 different things. Today we're on part 4, dressings. Part 1 was systemic factors in the wound. We talked about age, gender, smoking, alcohol, different diseases, cardiovascular disease, diabetes. We talked about obesity and nutrition, different medications, all right? In part 2, we went to local factors of the wound. We focused on oxygenation of the wound. What does hypoxia do to a wound, okay? We talked about inflammation, infection, foreign bodies, and then the different characteristics of a wound, whether it's a big wound that has a huge surface area or if there's associated crush injury, all right? Then we got into part 3, which is wound bed preparation and debridement. We talked about that TIME acronym, which is tissue debridement. We went through inflammation, infection, getting rid of biofilms, getting into moisture control, and then epithelial edge advancement. So those 3 parts, if you haven't had a chance to look at them, go ahead, check those videos out. They are prerequisites to understanding how to care for wounds. And today we're going to get into dressing. Now, one thing I want you to remember is we have to treat the patient first. Treat the patient, then treat the wound. Don't get distracted. Now, that has to go with basically all pathologies in medicine and surgery. Don't get distracted by that pathology. Treat the patient first. And with wounds, that gets to those systemic factors and how we can optimize those for wound healing. When we get into dressings, we have to start asking ourselves a few questions. Now, first is, what is an ideal dressing? I'm going to get to that. Before we talk about the ideal dressing, we got to ask some questions about the wound itself. What was the mechanism of injury? Is there injury to other structures? So for example, is there a fracture underneath this wound? Is it an open fracture and you have bone exposed? Okay. Is there nerve damage? What is the risk of contamination? So was there a lot of dirt and gravel and foreign body within this wound? Is there substantial tissue loss? Was there vascular damage or vascular injury? Do you have good distal pulses and perfusion of this wound? And then, of course, what is the tetanus status of the patient? Does that need to be updated? So remember to ask ourselves these questions first before we start thinking about how to dress that wound, okay? So what is an ideal dressing? Now, we got this guy here. He's bandaged head to toe, covered in gauze. Is that the ideal dressing? We're going to get to it, okay? So to ask yourself, what is an ideal dressing? Consider these things. Does the dressing give us good moisture control? Does it limit bacterial contamination? Does it enhance epithelial edge advancement? Does it promote angiogenesis? Is there effective temperature control? Does it assist with debridement? Is there gas exchange through that dressing? And then, of course, does it provide protection? Is it non-adherent, so it limits pain when you have to change that dressing? And then, is it sterile and non-toxic? So these are some of the components of an ideal dressing, and we're going to get through all different dressings today. I'm not going to be able to talk about every dressing in the world, but I'm going to get through the major headings, okay? And what I want you to think about when you're considering a dressing is this an ideal dressing for this patient and this wound? And can I match the dressing to the wound? Okay, so consider that as we go through each of these different dressings. Now, I always like to go into a bit of history when I'm thinking about this, and I found the history of wounds particularly interesting. We have been taking care of wounds for thousands of years, all right? Now, this is a bust of Hippocrates, but we've been taking care of wounds long before that. In 1650 BC, it was noted that we were using plasters and clay coverings of wounds to help them heal. Now, one of the guiding principles was that covered wounds tend to heal faster. And we're going to get into why that might be the case. But for a long time, for thousands of years, we were covering wounds with different sort of fabrics and other creations so that we could get those wounds to heal. And it wasn't until the 20th century that we started to have some answers to these questions. So how do we get moisture control and control that exudate? How do we limit bacterial contamination or promote angiogenesis and collagen laydown? So in the 20th century, we started to have some materials and fabrics that allowed us to help with wound healing and make a paradigm shift away from, what we had been really doing for thousands of years. Now, why do wounds that are covered or closed heal more quickly? Well, closed wounds heal more quickly because they're exposed to complement factors. They're exposed to particular proteases. They're exposed to growth factors and chemokines that are going to attract the cells needed for wound healing. And what's that going to lead to? It's going to lead to reepithelialization, promotion of angiogenesis, and collagen laydown during that proliferative phase where our fibroblasts are going crazy. And of course, if you haven't watched the Wound Healing 101 video, that's when I get into the different phases of wound healing: coagulation, inflammatory, proliferative, remodeling, the different cells involved, whether it's the neutrophil, macrophage, fibroblasts, and of course, all the different events that happen. So definitely check out that video. But now let's get into those different types of dressings, okay? So what is a traditional dressing? So whether it was clay covering or now gauze, okay, this really serves to just cover the wound. And we usually don't use these too much today because number one, they don't really provide much control of moisture, control of exudate. They don't limit bacterial contamination. They don't really promote any collagen laydown or angiogenesis. They do provide some protection, but they can also be quite painful to remove. So we typically don't use traditional gauze as a primary dressing, but we may use it as a secondary dressing, for instance, to support an underlying foam dressing, and I'm going to talk about that in a little bit. So traditional dressings like gauze are either used in very superficial wounds or to support an underlying modern wound dressing. So what is a modern wound dressing? Well, there are 4 different types that we'll touch on today. The first is passive wound dressing, okay? Second is interactive wound dressing. Third is bioactive wound dressings. And the fourth would be medicated wound dressings. And we'll get into the details of each of those. So what is a passive wound dressing? So a passive wound dressing is much like their traditional dressings. So this would be gauze or 4x4 pads, and that's used to support or cover, protect the wound that's healing underneath, but they are passive. They don't really actively promote angiogenesis. They don't really control moisture, and they don't limit bacterial contamination, which are some of those components of an ideal dressing. So passive dressings are usually used in support. Perhaps you have the Kerlix gauze that's supporting a dressing underneath, or some 4x4s that are going over the top of a wound. One of the ways we do use these in modern wound care is if we have a contaminated wound and we're doing wet to dry dressings, remember that's mechanical debridement, we're going to put in some gauze into that wound, and then we're going to be changing that twice daily, making sure it's wet to dry, providing a moist environment. That helps mechanically debride that biofilm, get that bacteria or other tissue that's limiting wound healing out of the wound. So that's one way that I would use a passive dressing. Now, the first type of modern wound dressing we talk about are semi-permeable film dressings. Now, a commercial example of this would be Tegaderm. So this is a film that promotes gas exchange, both oxygen, CO2, water vapor. And this is used to cover a very superficial wound, okay? It can promote autolytic debridement. We talked about that in the previous video, okay? It can promote autolytic debridement, and it can also provide some protection to the wound. Now, I'll use this in perhaps an abrasion. I may also use this to support a wound closure. So if I've excised the skin mass and I do a primary wound closure, perhaps running a monocryl, I'll probably either put Dermabond over that wound, or I'll place a semi-permeable film dressing like a Tegaderm or an Opsite over that wound to assist with the healing process. Now, the nice thing about these wounds is they're highly elastic, they're very flexible, so they can go over wounds that have difficult contours, okay? One of the bad things about these dressings is that they're not good for highly exudative wounds. So initially, when nylon dressings were used for this semi-permeable film dressing, highly exudated wounds led to local tissue maceration. So if you do have a highly exudative or very moist wound, this is not going to be a good wound choice. This is good for abrasions or to support primary closure of a wound. The next type of dressing I want to talk about is the semi-permeable foam dressing. So the semi-permeable foam dressings, and a good example here would be Lyofoam. Another one would be Alevine. So these have hydrophobic layers on the outside, hydrophilic layers on the inside. They can be either adhesive or non-adhesive, and they can be used in granulating wounds or wounds with a high level of exudate. Now, the nice thing about these wounds is they also are quite flexible and they can be used in difficult areas. For example, a sacral decubitus ulcer, where you have a lot of moisture and a lot of exudate, and that foam is going to absorb that. And in addition, because you have such a great amount of absorption, you typically don't need a secondary dressing, okay? So these foam dressings, whether it's Lyofoam or Alevan, they are typically good for granulating wounds with a high level of exudate and moisture. These foam dressings are not good for dry wounds or dry eschar or low exudating wounds because they depend on that exudate to assist with the healing process. The next type of modern interactive wound dressing are hydrogels. Now, hydrogels are non-soluble, hydrophilic synthetic polymers, okay, that have a very high water content. Because they have such a high water content, they provide moisture to wounds to assist with that healing process. They assist with angiogenesis and the development of granulation tissue. They assist with re-epithelialization. And because of that high water content, they provide a cooling effect to wounds, and they are also non-painful when it comes to changing this dressing. Hydrogels are typically good for low exudative wounds because of their high moisture content, and they've been shown to assist with all stages of the wound healing process. They can be used in a wide variety of wounds. One of the downsides is because of the high moisture content, if you do have a highly exudative wound, you can get some tissue maceration. You can also get bacterial proliferation because these hydrogels don't have antibacterial activity. So the commercial dressing I have here is Aquaderm. So that is a hydrogel. It's transparent so you can see the underlying wound healing, and it's also easy to apply, provides a nice cooling effect. Okay, so let's get into hydrocolloid dressings. So the hydrocolloid dressings are really popular dressings for low and moderate exudative wounds, okay? So these dressings have two layers. They have an outer water impermeable layer for protection. Then they have an inner gel forming layer, and that is usually made of either carboxymethylcellulose or gelatin or pectin, okay? And when that inner gel forming layer interacts with the wound exudate, it forms this gel that provides moisture to the healing wound. These dressings are nice because they are relatively painless to remove because of that gel forming layer. They are not so great with highly exudative wounds. So you can imagine that exudate is going to form a gel, and if you have too much of it, you're going to get that tissue maceration, even bacterial contamination of the wound. So these are great for light to moderately exudative wounds. That may include a pressure sore, that may include a traumatic wound, or even a burn. They're also good in wounds in children because they're quite painless to change. So two commercial examples I have here, Tegazorb in Granuflex. So it is indicated in partial full thickness wounds, so pressure sores, also donor sites for skin grafting, and has been shown to be really effective in these low to moderate exudative wounds because of that nice gel formation. Now, the next group of dressings are the alginates. Now, alginates are sodium calcium salts. They're derived from seaweed, and they have exceptional absorption capacity because of this hydrophilic gel formation from those alginate salts. Those salts can limit wound exudate as well as limiting bacterial growth and contamination. They've also been shown to activate macrophages within a wound. Now, we talked about those in Wound Healing 101, okay? And one of the things these alginates do to macrophages is stimulate them to secrete TNF-alpha, which is one of the inflammatory signals for wound healing. These dressings are used for light and moderately exudating wounds. They do form that gel. They have a tendency to dehydrate wounds, so you might need to use a secondary dressing with these. And one of the commercial examples I have here is Zorbzan. Now, Zorbzan is a dressing with a insoluble calcium alginate, okay? And when that calcium alginate interacts with the wound exudate, it forms a sodium salt. That sodium salt is soluble and produces that hydrophilic gel to promote wound healing. So again, these alginate wounds, they have a nice absorptive capacity for low and moderately exudative wounds, and they also have that stimulating capacity for activating those macrophages, TNF-alpha, which is an inflammatory signal, and they have some antibacterial properties. Now, the third type of wound dressing that we're going to talk about in these modern wound dressings are bioactive dressings. So bioactive dressings represent really a scaffold of some sort of activating compound. So for example, in this dressing, Puricol, this is a collagen dressing, and collagen stimulates fibroblast proliferation for more collagen laydown, as well as re-epithelialization of the wound. Another example would be here with Hyalumatrix. This contains hyaluronic acid. Now, hyaluronic acid is a component of the extracellular matrix, and this also assists with wound healing. Now, there are a number of bioactive dressings available, whether you're using a collagen scaffold or a hyaluronic acid scaffold. I'll put some links in the references in the show notes there so you can get a better idea of how these work, as well as a few papers that have demonstrated their effectiveness. And they are going to provide answers to a lot of those ideal dressing questions. So, do we have moisture control? Are we antibacterial? Are we promoting angiogenesis and collagen laydown? Are we protective? Are we sterile, non-toxic, easy to change? So these bioactive dressings are really fascinating, and I definitely recommend you take a look at them. I find myself using these bioactive dressings. For example, if I have a wound dehiscence in a neonate and I need to have some healthy granulation tissue, I may use a collagen scaffold dressing, perhaps change that every 72 hours. I'll support that with a secondary dressing, like a Mepilex or something that's easy to change without having any injury to the epithelium or surrounding skin. And that's going to assist me with getting that wound to heal. So the fourth type of dressing we need to talk about are medicated dressings. Now, medicated dressings are going to be some sort of scaffold, some sort of base layer with an additional medication or drug associated with it. The commercial example would be Puricol AG or Puricol Plus AG, which should be a collagen scaffold dressing that's medicated with silver, which is going to have some antibacterial properties. Okay, so if you have a contaminated wound, that silver is going to limit bacterial growth and help to keep that wound sterile as the healing process continues. So I'll use this if, for example, I do have a contaminated wound. Perhaps there was a surgical site infection that led to a wound dehiscence, and now I have an open wound. Perhaps I've done a wet to dry for the day, or I've needed to debride that wound, and now I need it to heal. I'm going to use something like a collagen scaffold dressing that may be silver impregnated, so I can have those antibacterial properties. Assists me with that wound closure. So today we talked about a ton of different dressings, okay? We went through traditional dressings, and now we're just using those for support of the primary dressing. So that would include 4x4s or gauze, Kerlex. Sometimes I will use these traditional gauze dressings if I'm doing mechanical debridement with a wet to dry dressing in a contaminated wound, okay? But really for wound support, secondary support. We then went into the modern wound dressings. We talked about passive dressings, and then we got into a variety of interactive dressings, talking about those hydrogels, hydrocolloid dressings, talking about alginates. We talked about those semi-permeable films like Tegaderm. And then we went even further and we got into bioactive dressings. So bioactive dressings may be a collagen scaffold, maybe a hyaluronic acid scaffold, and then of course medicated dressings, where one example I gave was with silver impregnated dressings because of that antibacterial property. Okay, if you enjoyed this, definitely give it a like, share it with your friends, leave a comment. What dressings have you found particularly effective? Okay? And what did you learn today? Share that with me. I love engaging with you guys. The next talk is going to be on wound closure. We're going to do a review of primary closure, secondary closure, delayed secondary closure, what that means, when we might use it. All right? As always, stay safe, study hard. I'll see you next time.